me. I can't see you all on one screen. You're on 5 screens, but I will be able to flick from one to the other. And in any case, I've got the names of the people up, so it should be fine. So welcome, everyone. I am Councillor Ruth Dombey. I'm leader of the Council, London Borough of Sutton, where I chair the Health and Wellbeing Board. And I co-chair this meeting as I'm the local government lead for health and social care in South West London across our 6 boroughs. So can I welcome all of you to this meeting of the Partnership Board. We really would have preferred to have met in person, but as you all know, there are train strikes, and for many of us, getting around South West London without trains is really quite difficult. So it's a shame we're having to do this online, but I'd rather do it online and have everyone here than try and get everyone to come and then end up with a smaller group of people. So we'll certainly be meeting in person next time, but needs must this time. Can I remind everyone, please, to use the hand button if you want to ask a question or contribute. As I say, I can't see everyone on the same screen. I don't know why my large gallery option is grayed out, but it is. So please use the hand function so I can see if you want to come in. And please stay on mute if you're not speaking, because it helps with the sound quality, and there are a lot of us in the meeting. The meeting is being recorded and broadcast live, which is fine, and it will also be uploaded onto the ICS website after the meeting, and a version with British Sign Language will also be produced and uploaded, which I think is really important, and I'm pleased about that. As you all know, this is a meeting held in public. It's not a public meeting, although we do try and involve everyone as much as possible. We're going to do our very best to avoid jargon and acronyms, but as we all know, it is very easy to fall into that bad habit. So if anyone participating in the meeting feels that we're using jargon or abbreviations that don't make sense, please put it in the chat and someone will come in and explain. There's a glossary of terms on the website, but we'll do our best to make sure that isn't necessary. We normally take live questions from members of the public, but because we're online, we don't have the software that allows us to do that. But members of the public have had the opportunity to submit questions in writing before the meeting. And because we've got a lot to get through, we want to have as much time as possible for discussion. We've asked all our presenters to treat all the papers as read, just to highlight the main points, so there's every opportunity to have a proper discussion. So apologies we've received from Joe Farah, place member, Karen Broughton, health member, Fenella Merry, who's a local authority member, Dino Pardonani, place member, Cyanathan Ganesarathan, who's a place member, and Carol Cole from Community Healthcare. We haven't had any further apologies, so the meeting is quorate. And can I take this opportunity to give the warmest possible welcome to Mike Bell. Many of you will have seen him already, both at the partnership meeting, the conference that we had, but also at the board meeting, the ICB. We are really, really honoured and lucky to have Mike with us. Mike has huge experience in both local government and the health sector, and I think he will be an absolute asset to this partnership. Mike and I will be co-chairing the partnership board, which is the arrangement we had before, and we've worked out between ourselves, between each other, how we're actually going to do that. So there'll be some handing over during the meeting, but obviously we're both co-chairs and we'll both come in as appropriate. But very much a welcome, Mike, and we're delighted to have you on board. Declarations of interest. I'm asked to ask members if you have to declare any interest not already on the register. If it's already on the register, that's fine. And to declare any interest arising from the agenda or papers presented for the meeting today. So I'll give you a second if you need to put your hand up to declare, but I can't see anyone declaring, so we're just being asked to note the register of interest. Can I have some nods and thumbs up, please? Thank you very much. The minutes of the previous meeting held on the 19th of April are included for approval. Can everyone agree they're an accurate reflection of the meeting, please? Lots of nods, thank you, and thumbs up, excellent. And there were 2 actions from that last meeting, both of which have been closed. So can I ask the board to approve the minutes? We've done that, and I'm seamlessly going to hand over to Mike. Mike, welcome to your first meeting.
Ruth, thank you very, very much, and thank you for your warm words at the beginning. It's fantastic to be here. I think that South West London is in a great place. I think we have a fantastic partnership that we can build upon. As you said, I have been involved in South West London for quite some time, it's really pleasing to be bringing to this meeting the work of the ICP strategy. Way back last summer when we kicked off that piece of work, I was a member of the ICP, and it's a real honour to now be the co-chair with you, Ruth, as we formally launch the ICP strategy and in the coming months and years get down to work in terms of delivering the really ambitious goals that we've set ourselves. I think we can be immensely proud in South West London of the way in which we have engaged our population, our communities in developing the strategy, and I would like to pay a particular tribute to the work of our communications team, not only for producing what I think is a lengthy but very attractive and very easy to read document, but also one which more importantly reflects the views of the people that we serve across, the views of our partners and the people that we serve across South West London. I'm going to hand straight across to Rachel Flagg, who is going to introduce this piece of work. So Rachel, could I bring you in, please?
Thank you. Hi everyone, I'm Rachel Flagg. I'm Director of Integrated Care Partnership Development for South West London. At the April meeting, this board agreed the feedback from the strategy discussion document and also agreed to run a partnership event on the 24th of May for the joint action planning for the strategy. So we're just going to show a very short video now before we get into the discussion, which will sort of act as a reminder for people who were at the event, but also give a flavour of it for people who weren't. So I'll just ask Ben to run the video now. Do people have sound? I don't, Ben.
No sound.
This is an opportunity to do something very different, to bring together all of us from all different parts of the community, all different sectors, different people and different voices. Today has to be meaningful and it has to have purpose. Above all, it needs to be about action.
I think what's really exciting about this partnership event is that we're bringing people together from public sector bodies, the NHS, local authorities, voluntary sector, but also real community people as well, and thinking about how we can work together to really improve the health and well-being of people living in South West London.
We've got more than 200 people gathered here today, all of them bursting with ideas on how we can work together and make a real difference for the health and care of the population in South West London.
So we sometimes, I think, as professionals assume that we know what's best for patients and for local people, but actually we have to listen to what they have to say to us about what they want and what they need, rather than us telling them what we're going to deliver.
For me, it's really important that we get across the community voice, because we are the community and we are representatives of the community. Whether you're looking at things like long-term conditions or health inequalities, we have the voice of the community, and it's really important to hear that voice, because you can't meet a need unless you know the need.
In terms of looking at inclusivity with young people, in terms of diversity, and I feel like, you know, as a collaborative, we can genuinely make that change for the long term.
The more that we can prevent people becoming unwell, the better it is for them. They can enjoy their life more, but I think we can only really do that if we work together.
Yeah, I feel like my opinions have been listened to today and also respected.
The main thing is, you know, it's all great saying that, oh, we're going to make all this change, but is actually doing this change? A lot of it is to do with funding, but there are a lot of ways, you know, with getting sort of volunteers, people who are more than willing to help young people, and even young people themselves volunteering and helping out. It's just everyone helping everyone, I think, which is a very important thing.
The message I'll be taking away again from today is we've just got to keep thinking about how we can release focus and attention and resources towards prevention and helping people live independently.
I honestly think this is a once-in-a-lifetime opportunity to do things differently, but we can only do it if we bring together the voices of everyone in the community, not just the people that we're used to hearing, but everyone, because this is about all of us. This is about our young people and their future. This is about our older, more elderly residents and what they want from us. We need to honestly talk to people, listen to people, understand what matters to them, and understand how we can actually put it into practice and make it happen.
Thank you, Ben. So following that event, the workstream co-leads from local government and the NHS and the teams around them have worked up the content for each of those strategic priorities, and that's what's for your comment today in the draft strategy. We've got several of those co-leads in the room today because they're also members of this ICP board. So I'll leave it to them to say more and also allow time for other board members to give feedback. Just like to say thank you to all of those co-leads for the work so far and for the really helpful feedback we've had from colleagues at South London Partnership, Sarah from VCSE Alliance, and also Alyssa from Healthwatch. So the ask to the board is to give feedback and hopefully agree the strategy so that we can move on to the next stage, which is of course delivery. And key to that will be the agreement of shared outcomes, which we'll bring back to the board in October, along with a forward plan. So you'll be able to see, rolling updates from each of those work streams. Thank you.
Thank you, Rachel. And I think the video really captures some of the energy and enthusiasm in the room on that particular day. And I think that the document that we got actually really captures the ideas. So a big thank you to the workstream leads and the people participating in them for driving that. Very happy now to receive comments and questions from any members of the partnership. So if you could raise your hands if you'd like to make a comment. And I can see Zara has a question or a comment. So Zara, straight across to you.
Thank you. Sarah, Director of the South West London Voluntary and Community Sector Alliance. So as you know, Rachel, I did flag up at the ICB meeting as well, the fact that I think the workforce development part of the strategy does not reflect the voluntary sector at best. It was quite difficult on the day to kind of include ourselves into those conversations, but if we're talking about transferable workforce, between organizations, between places, I think the voluntary sector has a massive role to play, and I would like it to be a bit more relevant within the strategy. Also considering that 80% of the innovation fund is going towards workforce development.
Thank you. Should we take a couple of comments before we come back to you, Rachel, for conclusions? And Zara, just so that people know that you are the representative from Voluntary Community and Social Enterprise Alliance across South West London. If I could go to Nicola, and Nicola, if I could ask you to introduce yourself in terms of your role as well, and then over to your question.
Yeah, thank you. So I'm Nicola Jones, I'm a GP and I'm the primary care partner member on the Integrated Care Board and in this partnership. And I was one of the co-chairs at the meeting. So I just wondered if at this point you wanted some reflections on it, or, I'm happy to feed in on how it was for us, as it were.
I think it'd be great to have your reflections, Nicola. Do you want to share those with us?
Yeah, great, thank you. So my co-chair was Annette McPartland, and it was quite interesting because we hadn't actually met face to face at all before we did the actual day. So we managed through osmosis or something, or perhaps it was Rachel and the team's support. But we were doing the frail and elderly people section. So we had a really knowledgeable, passionate, quite a mixed group of people in our workshop. We had great input from local authority, health colleagues, and from people from the wider partnership. We had people from within our communities, some with experience of being carers or relatives of people with dementia or just older people, and input from the voluntary sector as well. So it was a really good mixed bunch. I thought it was very appropriate. The people that were there, I think, really worked for us, and it was clear there was a lot of motivation in the room. People were really enthusiastic about improving the lives and health of these vulnerable and frail older people. So Annette and I, we sort of kept our options open really on the subject matter initially, but after a bit of work the group honed it down to these 4 areas, and we agreed we would work on social isolation, falls prevention, dementia and carers. And you'll see from the paperwork that's come through already, you know, we've got lots of possible actions identified in each of those areas. And we decided we were going to choose one area that would be the sort of legacy of the event for us. So we decided that we'd focus on making South West London dementia friendly. And we thought that this would be something that everyone could get behind, because it could include health and care professionals, of course, but more than that, it could involve working in and with communities to make sure that people are understood and cared for in the communities that they live in. And it could be something that our voluntary sector would want to get engaged with and be involved in. And it could even expand to organisations and establishments outside of the usual sectors. So, for example, we thought a news agent that's dementia friendly could have a really important effect on a person's life if they feel safe to have a daily walk somewhere familiar where they're treated with kindness. So that was our one big focus, really. But we also had plenty of creative thoughts around falls, carers and social isolation, which we hope will be welcomed by this group, the wider partnership, and be taken forward by everybody.
Great, thank you for that, Nicola. And it was really good to get the that shared perspective, and I think a really good example of partnership between boroughs, Wandsworth and Croydon, plus all of the other participants, and also between the health sector, you as a GP and Annette as the Director of Social Care in Croydon. So really creative session, and I think the outcome from it is really well focused on what's needed. Can I go to Anne Beasley next? And Anne, again, could you introduce yourself for the benefit of the wider partnership?
Thank you, Mike. So as Mike says, Anne Beasley, I'm chair of South West London and St George's Mental Health Trust, here as a provider chair of mental health services. So well done for turning what was an immense amount of output from the 24th of July into a kind of a very readable document. I guess my sort of thought on it is there's an awful lot in it, and there's an awful lot therefore to do. And I thought the one bit that was kind of missing for me, and this comes back to sort of how do we prioritise, doesn't it? If we were to do a one page on what's going to be different in 2028 in terms of outcomes, I think that might help us sort of hone it down a bit, because there's lots of big ambitions and not perhaps yet enough specificity about what we're actually going to do.
Thank you for that, Anne. And I'm sure Rachel will be thinking through an answer on that. I'm sure she's already got some answers in terms of how she'd like to take that forward. In fact, should we go to Rachel to pick up on those points first of all, and then I'll come in and bring the other partner members who would like to come in with their points. Otherwise, Rachel, you'll be overwhelmed by the number of questions that we're asking you to address. So over to you, Rachel.
Thanks, Mike. So Sarah, first of all, yeah, really important that the workforce section does reflect the voluntary sector as well as local government and the NHS. I think what would be really helpful is to get you more involved with the ongoing development of that work stream and bring you into the task and finish group. So if you're up for that, that would be really helpful. Nicola, thank you for your reflections, and I think some of those really big symbolic actions like dementia friendly South West London, if we can pull some of those things off, I think that would be a great achievement for the partnership. And Anne's point on the fact that there's a lot there, I think you're right, we do need to prioritise, and yeah, I really like your idea of a one pager describing what will be different in 2028. And I think that's definitely part of the next stage, is that kind of agreed set of simple, clear outcomes that we can coalesce around.
Fantastic, thank you for that, Rachel. And if I can go to John Byrne next.
So, thank you, Mike. So myself and Iona actually chaired a work stream together, which was great. But it was just to sort of reassure Sarah with her first point about the role of the voluntary sector. So we in our work stream, which was about prevention, health prevention, long-term condition, self-management. We sort of factored in around perhaps we need to think something about a whole system approach to obesity, amongst many other things. And we recognized that there was going to be three key enablers for this, and community empowerment was actually a key enabler in order for us to deliver this work stream. And in that enabler, we recognise the role of the voluntary and community sector. And not just in doing that, we recognise the role that we need to find a way to support and commission them to provide some of the services as part of our whole system approach to managing obesity, because we wouldn't be able to do that otherwise. So, Sarah, in terms of the minutiae and the detail, I can reassure you that from terms of our work stream, not just because we wanted it, because of the voices that were represented at the table of the community and the voluntary sector, it's absolutely in there. So it's not just about workforce for me, it's about how we commission our community providers, our sort of voluntary sector stakeholders to deliver some of this stuff, because ultimately that's the only way we will achieve our whole system approach here.
Thank you, John. And if we can go to Douglas, Douglas Flint next. Douglas, again, if you could introduce yourself, that would be great.
Yeah, thanks very much. So Douglas Flint, I'm the chairman of the Royal Marsden. I thought it was an excellent document, and as others have said, there's a huge amount of ambition. And kind of my one comment was, would it be helpful to have a page somewhere? You can kind of identify elements of it throughout the document that sets out the challenges and risks to the strategy, because we're in a complicated world at the moment, and there are a lot of risks to the development of this, or to the success of the strategy, some within our control, some not within our control. And I just wonder if you're setting out this kind of ambition to sort of say, what are the risks and challenges that we have to overcome? I think I would be used to seeing that in a document that sort of, so that people can focus on what are the things we need to think about, and what are the things we might need to come together to lobby others to address, so that we can be more successful in delivery. Just a thought.
Thank you for that, Douglas. And we've actually got another 5 people wanting to come in, so I'll take those 5, but I think we'll need to call it a day at that point in order to be able to move on with the agenda, not least because we've got some really exciting items coming up where we're going to hear from some of the practical projects that we've done over the past year, which I think give a really good spotlight to how we're working as a joined up system with our communities. Anne Popovici, please.
Thank you, Chair. Anna Popovici, Director of Children's Services for Wandsworth and co-chair for the Maternity and Young People's Board. I just want to say well done to everyone. The ambition of the strategy is commendable, and there is nothing in the priorities that we will not or could not fundamentally absolutely get behind. But I think for us, it's clear that if we are to address these aspirations, we need to work collaboratively and collectively and fundamentally differently as partners. I think we need to be bold and brave to address the shared priorities. And I think, picking up on a colleague before me, single biggest point I want to highlight, the single biggest risk in driving and seeing this strategy becoming a reality in Southwest London is our workforce, our biggest asset. So, an invitation maybe for a greater conversation around our biggest asset, the workforce. How can we work together? How can we think together about our workforce and think outside the box with that? Thank you, Chair.
Great. No, thank you, Anna. I think that's a really helpful contribution. If I could go to Gillian Norton next, please.
Thank you, Mike. Gillian Norton, I chair St George's and also Epsom St Helier Trusts. Like so many speakers, I commend the document. I think it's extremely readable and very clear, and so that's great. But I think I'm building on points that Anne, Douglas and Anna just made, really. And for me, it was very striking in the children's section that a lot of what we describe is what we're already meant to be doing. And despite people's best efforts, we're not doing a lot of it as well as we know we should, and we're failing children as a consequence of that. And some of that is about context, workforce, resources, and all the rest of it. So I think we have to be honest with ourselves about that, and it is, I think, incumbent on us to be really, really clear about how we prioritise and recognise that we can't do it all. Thank you.
Great. Definitely food for thought. I know Rachel will be reflecting upon that with the team in terms of how we make sure that we deliver the key priorities. Carolyn Dwyer.
Yes, thank you. I just wanted to reflect many of the comments that people have made. As the lead on the workforce stream, there was a huge amount of rich information that came back from the event. And we were very keen in the workforce stream to focus on a few actions that could make a measurable difference and that could potentially be scalable afterwards. And that is on top of a huge amount of initiatives that we are all doing across the partnership already in different ways. So that this wasn't trying to stop or prevent any of the existing amazing work that's going on. It was about that specific, what is it that we can do together on top of what we are already doing that might make a difference. And we really welcome Sarah and Anna and any others joining the task group to turn this into a really dynamic action plan and make it happen. Thank you.
Thank you for that, Carol, and thank you also for the work you've been doing around workforce. It's really been really valuable. If I can go to Ruth Dombey next.
Thanks, Mike, and I absolutely take on board the points about we can't do everything and we need to focus on what we can do that will actually make a difference. The work of the subgroups obviously is going to be key to this, and I'm glad that we're talking along these lines because it's absolutely essential that within the discussions of the subgroups, they actually are realistic and pragmatic. We can't change the world overnight. We need to think about where the partnership can bring added value. I think Anna's point about workforce is really well made, and without detracting from the work that Carolyn and others are going to be doing on that particular priority, I do think the other 5 subgroups need to have that as a thread in the work that they're doing. I certainly don't want to duplicate and make life more difficult for everyone, but if I think about the other 5 priorities, the other 5 subgroups, actually workforce is equally important for all of them. So I think there is a common thread there. And then just quickly, just finally to say that we have 6 priorities, we have 6 boroughs, and we have 6 chairs of health and wellbeing boards. And I had a really helpful and interesting conversation between the 6 of us. As a result, we would be quite keen to be a sponsor for each of the priorities. So again, we're not asking to be full membership. We recognise that the work is beginning and is important, but we're talking amongst ourselves. We're going to divvy it up between us and then talk to the relevant subgroups about how we can add value, because we are elected members. We have the voice of the community. We can work just like Zara to ensure that not only we're bringing the voice of the community to the work that's doing, but we can also champion it externally. So Rachel, just to let you know that we're going to work out between the 6 of us who wants to do what. Helpfully, most of us are saying we don't mind, we think all the priorities are important. We'll let you know which Health and Wellbeing Board chair is going to sponsor which particular work stream, and then we can bring some of our experience and expertise in as well. Thanks, Mike.
And thank you, Ruth, for that. I think that offer from the Health and Wellbeing Board chairs is incredible. I think it's a real testament to the work of the partnership and how things can carry forward. I think the sponsorship of the Health and Wellbeing Board chairs will be really powerful. Can I also now finally bring in Brenda, please? Brenda Scanlon.
Thank you very much, Mike. Brenda Scanlon, I'm a place representative from Croydon. I'm chair of Age UK in Croydon. I wasn't unfortunately able to get to the event, but I have read the strategy and I've looked very closely at the documents subsequently. I'm going to make a comment, and I hope this is appropriate, and I don't know who was there at the day, but what impresses me is that if we are taking a whole system approach to how we are going to deliver this strategy, one of the most important elements of that is how we're working with key organisations within what you could only call the independent sector. So I'm very struck with the fact that if you think about workforce, the majority of our workforce, particularly in social care, is working in, I'll use that old-fashioned term, private sector organisations. And similarly, just thinking about the comments that were made before about the work stream on older people and making South West London dementia friendly, we are not going to be able to do that just from within the health and social care and voluntary and community sector perspective. So it's complicated about how we ensure we involve the other sector, which is so wide and varied. But I don't know if they were there on the day, but for me, there is something so crucial about making sure that if we're going to deliver this, it's actually speaking to the wider groupings and the wider sector within South West London. And there are, otherwise we'll be just, I hate to say it, speaking to ourselves again. And so I think there is that wider dimension. And I hope that's a fair comment, Mike. And they may all have been there on the day, but I just really want to flag that, because for me, this is the key to success as well. Thank you.
Brenda, I think that's an incredibly helpful comment. And I think certainly we face a particular challenge because we have so many private providers in the residential and domiciliary care space. We do need to find a way of engaging them. Their workforce is just as important as the statutory sector workforce in terms of the quality of life that we provide for our populations. And you're right, there is a wider conversation as well with the newsagents, with the hairdressers, if we really want to land many aspects of our strategy. So thank you for raising that, Brenda. I'm going to pass back to Rachel for any final comments and observations, and then we'll move on the agenda.
Thanks, Mike, and thanks very much for all of that feedback, which is really helpful and constructive, and we can certainly work with that. And I suppose just one thing that I would pick out of that, and I suppose many of you were speaking to it in different ways, is that bit about understanding our challenges and risks. And I think we can bring that back in our reports back to the board, because part of what hopefully we can do together is unblock some of those things and mitigate some of those challenges.
Rachel, thank you for that. And I think from the contributions today, I think we can safely say that the ICP strategy notes and delivery plans is approved. We will clearly have to come back to the board with regular updates, and we'll program all of that into our forward plan moving forward, so that the whole ICP feels engaged and involved in the way in which we move forward over the next 5 years. Rachel and team, thank you very, very much for the work here. You're not going away yet though, Rachel, because I'm going to keep you for the next item. Normally when I'm in NHS meetings and we start talking about governance, I groan inwardly. On this occasion, this is actually a really important item in terms of refreshing our governance, because it goes to the heart of the way in which we operate as a partnership. It's very, very much about making sure that everybody on this partnership board feels that their contributions have equal value, that our community sector doesn't feel that they're overshadowed by the statutory sector, and that everybody feels that they can play a part and they understand the roles in which they play. So, Rachel, I'm going to pass across to you for introducing this item so that we can secure formal approval for the changes to the governance arrangements.
Thank you, Mike. So the starting point for our integrated care partnership governance is what already exists in terms of partnership structures across South West London. And of course, there are many partnership forums at place level, but what we need to do here is ensure delivery of those collective actions we just talked about for the whole system. And I suppose importantly, it's about delivery. So we also need to make sure we've got the right support around those kind of task and finish groups. So it's not only about governance, about delivery. So I'm asking for the board's comments on the proposals that are in the paper, and for the board to ask the groups that already exist to review their terms of reference, and for those that are new to prepare them and ensure that they're really representative of the partnership in the way that Mike's just described. We'll also need to confirm following this meeting our joint senior responsible officers, because of course not everyone who was kind enough to co-chair at the event will be in a position to go on and play a leadership role in the delivery phase, but we're hoping that many of you will. We'll need all partners to put existing resources into delivery, so that we've got a sort of virtual team around all of the work streams that will build on the work people have done together thus far. We've actually already covered a little bit about how the wider ICP membership might be engaged in a meaningful way in the delivery phase, with that great offer from Ruth and the Health and Wellbeing Board chairs but also interested in other comments that people might have in terms of the wider membership being engaged. So that could be through being a named champion for a work stream or a cross-cutting theme. But that's probably all I need to say by way of introduction. So we can take comments.
So thank you, Rachel. And yes, we're very, very happy to take comments. I think that many of the proposals that are included in this item actually reflect some of the comments that people have made in the previous section about how we take things forward, how we make sure that people are engaged. So it feels like it's on the right track, but let's take some comments, and I can see that we've got Yemisi and Iona. Yemisi, if I can go to you, and if I could ask you to introduce yourself, please.
Thank you, Chair. Yemisi Gibbons, Chair of Croydon Health Services. In terms of the governance document, I think it's important to note that in the feedback strategy, they did talk about crossovers between mental health and CYP and health inequalities. And I think it's important that we reflect that into the governance, because it would be a shame to do all these pieces of work in silos. There's a fair degree of triangulation that should occur. And we will get benefits from those. So I think if we could formally highlight them in the governance structures, that would be beneficial. Thanks.
Thank you for that, Yemisi. And we'll go to Iona, one of the stars of our opening video.
Good evening, I'm Iona Liddington. I'm Director of Public Health, and I'm the Director of Public Health representative on the partnership. So it's a similar theme to Yasemi has said, that my concern is, if you recall, a couple of partnership board meetings ago, we kind of agreed for health inequalities to move up from a cross-cutting theme to be a priority. But I think one of my concerns is similar, that in order, if we look at prevention, self-care, longer-term conditions, that definitely will have a health inequalities theme to it. We've heard mental health will come through in several of the different places. So I guess my concern is, where are we going to avoid that duplication and ensure pieces of work are joined up? Because if we are really looking at whole systems approach, health inequalities cuts through as a lens in all of those. So I feel that whilst the document said a lot, it didn't quite capture how we're going to avoid that duplication or siloed working.
I think that they're both really helpful challenges. Let's go to Sukhvinder. Sukhvinder, would you introduce yourself?
Yes, good evening, everyone. I'm Sukhvinder. I'm Chair in Common at Kingston Hospital and also at HRCH, Hounslow and Richmond Community Health Trust. Yeah, I was particularly interested in the workforce proposals in the document, and actually the pulling together, the working with the social care teams, and I wondered if you could say a little bit more about how you would see that working, and whether you would envisage opportunities for learning and sharing between the different practitioners.
Great, thank you for that. And finally, Zara.
Hi, just a very quick point on the green agenda. I know it was a cross-cutting priority, and I think it's really important that somehow we find a way in the governance to make sure that all the task and finish groups have the green, agenda in mind. And the second point was probably an obvious one, but I think it's important that we continue to maintain the voluntary sector engagement in all these task and finish groups, and make sure that all the groups who came and more can contribute and can continue to be engaged in these task and finish groups.
Thank you for that. Rachel, your comments.
Thank you. So again, really helpful feedback. And I think, yes, that's really important that we do make sure we reflect the crossovers and don't act in silos. I think there's a few different ways we could do that, but we'll perhaps come up with some suggestions that we can be a bit more explicit about in the at the next meeting, whether that's kind of an exec group of co-leads or whether we do it through other means. On the issue of the workforce work stream, yeah, I think that's really key that we are learning and sharing between different practitioners, because that's how we'll get the value out of the partnership. So I think although probably the NHS People Board and the social care workforce group will need to continue to exist to do some of the things that they need to do for their own sectors, there will be a working group that feeds across into those and also includes that wider membership like the voluntary sector has talked about. And sorry, yeah, I think it'd be good to work through how we make sure that the voluntary sector are represented throughout that whole structure. And on the green agenda and the other cross-cutting themes, it might be that we want a named champion within each of the groups whose kind of role it is to make sure that those cross-cutting themes are really being genuinely thought about as we go through.
So Mike, I've just seen you come in. I'll bring you in briefly, and then we'll go to decisions. Mike.
Yeah, thanks, Mike. Sorry for coming in late. So Mike Jackson, I'm Chief Executive at Richmond and Wandsworth, and on this partnership represent the other local authority chief executives too. Sorry for coming in late again, Mike, but I just had a thought. Part of the way of getting at these cross-cutting issues is actually the need, which we've spoken about before, about having an outcome framework, because what matters at the end of the day is the impact we have, and we've recognised that that's something we need to develop. So I just wanted to say there's another dimension as how to get at that, and that's having some clear outcomes that we're aiming for. Thanks.
Great. No, helpful, Mike. On that basis, I'm assuming that people are comfortable with us with the proposal around reviewing the terms of reference for the subgroups. That feels like it's appropriate, and that we also look at refreshing the joint senior responsible officers. Before I ask for assent on that, can I bring you in, Graham Henderson? Graham, you may be struggling with your mute button.
Yeah, I did actually lose connection. Yeah, I just wanted to mention, it was mentioned at the very beginning, the offer from the Health and Wellbeing Board chairs. And Karen, I'd say very briefly, it is a reflection of the elected members to certainly have a more sort of direct involvement in some of the discussions and certainly formulation of the agenda. We'll come on to that later in relation to the ICP. But what we actually envisaged was that, as it happens, there were 6 Health and Wellbeing Board chairs, six local authorities. There are 6 main work streams, and we thought that each one of us could provide a sort of oversight role in relation to the elected members, and we're discussing who should actually take the lead in which. I would add that we're sort of looking for a fairly sort of light touch approach.
We seem to
SRO, etc.
Greg, your connection is very, very bad. So you're sort of fading in and out. So I think let's take up your suggestions outside of the meeting and make sure that they're incorporated as we move forward. Douglas, I see you've just placed your hand in the air. So briefly, can I bring you in, then we'll move on?
Very briefly, and maybe it's my relative immaturity in this role, but I completely agree that looking at the terms of reference and trying to get a cross-cutting holistic view across the Southwest partnership is important. But ultimately, once you've reviewed the terms of reference, what's the authority to actually bring people together and say, having done all this, we now need to do this differently, or you need to cede to this group? Or, I mean, how do you make a decision? I mean, in the corporate world, you'd have an executive committee, and ultimately a chief executive would make a decision. How does it happen here when you've reviewed all these terms of reference? How do you make it work?
I'm going to pass across to Rachel for that.
Rachel does it, yeah.
I mean, I think the truth is, Douglas, that this is a partnership of, this is a voluntary partnership. People are choosing to work together because of the benefits that we think that we, by working together, will be able to bring for our populations. And I think that that's been the strength of the partnership to date. It does depend upon people feeling the partnership is actually delivering. And therefore, I think there's a real commitment to making sure we're getting the outcomes that Mike has just mentioned. Rachel, was there anything further you wanted to add?
No, I suppose it's just to say that the groups, they'll have to operate, but on a basis of consensus, because obviously, people are there representing the sovereign organisations. But when we come together, it's about what we can agree to do by consensus together.
And Sarah, final words from you, and then we will definitely move on.
So I like Douglas's idea. I think the chief exec should make all the decisions, but I mean, on the basis that I can't, we'll go with the fact that actually we want to collaborate and we want to do it in a way that everyone agrees and that we can find a mutual agreement. We do all have a duty to collaborate, and as part of the statutory requirement now that came down in the legislation, we have a duty to collaborate together, and particularly as the statutory organisations with the NHS and local authorities, that is part of what we are required to do. Whether that would make us do it, I don't know, Mike, but I do think having some kind of mutual agreement and finding the best way, and I think actually we've done really well so far in getting to this set of agreed priorities, and I think if we can continue on the road that we have started together, I think we can be very successful in this.
I think both Ruth and I, as co-chairs of the partnership, actually believe that we can achieve a huge. The more we achieve together, the more we will want to achieve together. So I think the work that we've done to date actually provides us with a route through to make sure that people feel like this is worth participating in, and that we get the changes that we want. So I'm assuming that people are happy now for us to undertake the review, to review the senior responsible officers, and we will come back to a future ICP with the outcome of those discussions and the revised terms of reference. I am really pleased to be moving on. Apologies for being a little bit behind schedule to one of the really exciting parts of the agenda today. So I'm going to pass back the chair to Ruth now. So Ruth, over to you.
Thanks, Mike. And like Sarah, I'm very taken by your idea, Douglas, that one of us should just decide. But the joy of partnership working is that there's a huge amount of work that takes place outside of the meeting, so that when we bring proposals back to the partnership board, there is a consensus. But yes, I come from the corporate world. I absolutely feel your pain. But we actually, although it's messier and takes longer, we do end up, I think, with good solutions, and that's the joy of partnership working. Let's move on to the next item, which is about the Innovation Fund, and you'll have seen from the papers that we're talking about an interesting discussion that we had last time. We all know that the investment fund that we have some that we look at in our ICP. It was established in October 2022. We had to move very quickly last year, and I just want to say again, as I said at the last partnership meeting, I'm really grateful to Sarah Blow and her team for being so flexible to recognise the learning from last time and the fact that actually it takes time to set up bids, to understand how different parts of our partnership can actually put forward bids for the money that's available. We all know that our investment fund is made up of two parts. There's a Health Inequalities Fund, which is funded nationally, and then there's the Innovation Fund, which is funded annually by the Integrated Care Board. So I'm going to hand over now to Angela, who's going to talk us through the progress report and also then move on to some project spotlight. Angela.
Thank you, Ruth. So I'm Angela Flaherty. I'm one of the transformation directors at South West London ICB. This agenda item has two parts. The first part is about the fund that we ran in 22-23, and then we'll move on to talk about the future approach for 23 to 25. So the report that you've got in front of you for noting is just a brief summary of the schemes that have run over the last year. It just sort of sets out a number of the key schemes that have finished their delivery. There's 9 of them in total, and they've just brought to life some of the successes and some of the challenges that they've had. So it's a really short paper for noting. We've invited some of the schemes here today to share their learning and to share some of the highlights of their work. So I'm not going to hold up that conversation because they're really keen. We had lots of people wanting to come today, but we've narrowed it down to these 3 to share the work that they've undertaken. And I think we're starting with Catherine Heffernan and Amit Patel on Winter Fit. So I shall hand over to them. Catherine and Amit, are you there?
Yep, I'm here.
I'm there, and
Wonderful.
I'm doing the presentation, and Amit is here to answer any questions. So
Thank
shall
you,
I just
Catherine.
share my screen?
Yes, please.
And does my clock start when I start presenting, or has it started?
Catherine,
has
I'll
started.
share the screen.
Oh, okay. Oh, is somebody else sharing? Oh, I'm sharing. Shall I just go ahead? I move. Oh, things have just frozen. Okay, right. So I'm Dr. Catherine Heffernan. I'm Director of Health Improvement, and Amit Patel and myself were very lucky to have received some funding last year. Can people still see my screen?
Yes, it's not on slideshow, Catherine, if you want to move on to slideshow.
Okay, I'm currently on slideshow, but I'll just go ahead because I don't want to take up too much time. So basically, so we delivered an intervention called Winter Fit, which was a 15-minute bespoke intervention by community pharmacy staff to customers aged 65 years and old across Southwest London. And the reason why we worked with community pharmacies is that pharmacists and their staff already have very good relationships with those who come in for repeat prescriptions, and so are in a very good position to talk to customers about staying fit and healthy, but also to people come into a pharmacy for other things. So it allows for opportunistic public health interventions. We wanted to do a bit more than just giving messaging, however. We wanted to do a proper intervention. So based on the MEC approach, which is making every contact count, this was really about helping people to take that step forward to actually do some of the actions that we would like them to do, and also to create the amazing amount of help and support that's out there in Southwest London, so help people to know what they can do, for example, if they're lonely, what they can do if their house is not warm, where they can go if to sit in some warm spaces, etc. The scheme was very much focused on self-care and prevention and staying well during winter. So we're currently doing the summative evaluation, but I shall just share some highlights with you. 102 pharmacies signed up, 80 completed the training, and 57 were active participants. Basically, as you move further west, you have a sort of a decrease in the number of the pharmacies who actually signed up. The vast majority of pharmacies who took part were actually in our most deprived areas. And interestingly, those who did not do any interventions were in the least deprived areas. And the feedback was that they were a bit embarrassed to raise this with the customers that came in through the door. We did 10,000 interventions within 4 weeks. We were thinking it would be 6 weeks, but it was just overwhelming the amount of interventions that happened so quickly. The feedback has been that there was a real need, that the customers were so delighted that people were listening to them, were there to support them, were there to help them through the winter. And of course, using the MEC approach, this isn't about jumping on someone and telling them what they should do. This is about, how are you today? It's a bit cold, isn't it? What are you doing to keep yourself warm, etc. So it was a really good conversation, and also to a lot of our pharmacies actually followed up with their customers to see how they got on. There was the majority of our customers who used this were actually white British, although sadly a lot of the like 36% ethnicity was not recorded and 21% preferred not to say. So it's a little bit disappointing that we don't know the wider diversity of the customers that use this. Next, I'll go to the next slide. So the majority of the conversations were on winter warmth, followed by warm places and the cost of living support. However, over 50% of conversations did include what digital care and other care support was available for people in their homes, how they can increase their connectiveness, and how they can prevent falls and respiratory illnesses. Just over 14% were referred onwards to a GP, social prescriber, or social support. I've already mentioned that the feedback has been very positive from customers, and a couple of our pharmacies actually reported that some customers burst into tears. They were so relieved that somebody was there to try and help them through the winter that we had last year. So for me, going forward, and certainly what's coming out in our evaluation, is we now have a workforce in South West London who've been trained to deliver a MEC approach, but also trained to come into the personalised care and social prescribing world. We have a workforce here who are absolutely in a fantastic position to link in with people across South West London and help them not just through winter, but also through summer and through a lot of our other public health and prevention initiatives that we would like our population to engage with. So it's really key thing, I think, for us to build on this and help develop this workforce into a preventionist, helping to keep our population supported in good health, out of hospital, and help us improve our population health in South West London. So any questions? Am I allowed to ask for that?
Absolutely, Catherine.
Angela, maybe we'll move on to the next one, and obviously if people have questions on any of the presentations, but that was really interesting, so thank you for that. I think it's given a real sense of what you've achieved, and there's some learning there for the future as well. But maybe, Angela, it's best if we move on, do all three, and then we can have a more general conversation.
Okay, so I think it's Michelle Rahman who's up next with the Sutton and South Cheam and South Sutton Loneliness Project.
Thank you. And I'm here on behalf of Dr. Shazma Mawani and also Reina Barai, who's our community pharmacist, and they are the champions, the lead of this project. And it's a project that came through the integrated neighbourhood teams, which in Sutton consists of many of our community groups, our local champions, the statutory organisation, and anyone really that has an interest in each of the neighbourhoods. Now, I've got a clear message to thank the ICP for the Innovation Fund, because without it, we would never have been able to test the few really good ideas that we have. And I'm just going to share my screen and be very quick in going through a very short presentation. Just call it up. Here it is. Angela, if you can tell me when I am projecting that.
Will do.
Great, so hopefully you should be able to see the slides. I have projected it, it's probably just a wee bit slow, but I'm going to start talking. So I want to introduce you to Betty. Betty is an 88-year-old lady. She's been identified as being quite lonely by her GP and the prescribing link worker that works with her. She has capacity, she can make decisions. She loves being around people. She's quite mobile. She walks to the shops, she does all her own shopping and loves cooking. Her loneliness really got worse during the pandemic, but equally her daughter-in-law moved to the South Coast in 2020. You know, Betty does live alone, but she does live in supported living, so generally would normally have people around her. She speaks to family every day on the phone, but Betty is a frequent caller to her GP, and she's had up to about 50 contacts per year, visiting her GP for not feeling quite right, headaches, abdo pain, really sort of general things. And her average appointment is sort of 1 per week. She does have some long-term conditions. And she has some loss of vision, but also some issues with her sight and hearing loss. Part of the work of the Loneliness Project was really about identifying individuals like Betty, who we understand through the work that we've done through insights, particularly looking at our local data, that these individuals are quite high users of health services, both in general practice, but equally in our local hospital. So whether it's accident and emergency or admission as an acute admission. What the team developed was a neighbourhood holistic assessment that was based on another tool that they had identified. And it covered off some real basic information around her health, but equally around her social care, her social support, and just her general condition. But one of the things that was really important about the assessment were the 3 questions around loneliness that produced what's called a loneliness score. And it's called the University of California in Los Angeles Loneliness Score. And those 3 questions are really quite important, quite basic, but quite important. So how often do you feel that you lack companionship? How often do you feel left out? And how often do you feel isolated from others? So real core questions that have a score between 1 and 3, and then you add them up. If you're close to 3, you're not that lonely. But if you're higher to 9, you're at your most lonely. And the most important piece about this is that we know that social connectedness is really important. And for people who feel lonely, actually they can be in distress and can have other clinical conditions exacerbated as a result of that loneliness. And that's not me saying, there's some really good work that talks about that. So the team undertook to really understand Betty's loneliness. We used the score. We understood that despite regular contact with her family and living in assisted living, she really lacked that social connection and that social connectedness. We recognised that her main barriers for going out were not having a friend to go with. She told us that. She wasn't feeling very confident to go out alone anymore due to her vision getting just a wee bit bad, but also her hearing and incontinence. She had a carer that came around twice a day, but actually not really the same person each time, so really not developing that relationship. But she was also the most difference, what she described would be make the most difference to her was just meeting people, going out. And she really was able to reflect on outings that she had with friends, just wandering around the garden centre and having lunch. So just the stuff that you and I take for granted. What we did was mapped the discussion with Betty across a table that included how we're going to work with Betty to improve her health, understand her social care and improve that for her and with her too, but also what was available for her in terms of our community assets through our voluntary sector and local groups. And what could we do to really increase that social connectivity? And the rationale for those interventions was really about, we understand that the clinicians and others have told me that loneliness increases the risk of ischemic heart disease by 29%, stroke by 32%, but equally that increase in risk of declining dementia and progression of frailty, also the impact in terms of hospital admissions. So we knew we wanted to make sure that we were optimising her treatment to be sure that her long-term conditions were managed, but equally that we understood whether she was depressed, so really carrying out the depression screening, recognising that she's been having falls, making sure that we have support in there to really understand falls prevention and really have the continence nurse work with her so that she wouldn't feel embarrassed and could manage her incontinence. But around the social care piece, it was also, she likes going out. So making sure that she had information about the transport schemes locally, taxi cards, etc. And that social connection piece, really pairing her up with neighbours, outings, going out to cafes, but really taking notice and building that plan with her as her personalised care plan. So what we achieved, we've got that in the paper, so I won't go through it too much, but we were really, really happy that we were able to accurately identify residents at risk of loneliness, and we were very accurate with that. We were 70% accurate, and we know that, with that level of accuracy and working with our residents to develop the personalised care plan, we can really make a difference. So in terms of where we are going next, we're really clear that we want to train many of the individuals, both those within the statutory sector, but also the health and wellbeing coaches, our volunteers, on how to undertake the loneliness assessment. It's a really simple assessment, and actually if you're trained to do it and trained to do it well, anyone can pretty much do it. So we're looking at how do we skill up all of those who are in contact with our older people and make every contact count. But equally to make sure that we really understood that we don't take for granted those individuals who may be living in care homes or assisted living, because they too can become lonely. So really understanding that. And we're building that into the work that we're doing just in terms of our programme for loneliness. We're also building into the programme, linking in with the work that we're doing for the proactive MDT. So the money that we no longer have for the loneliness project, but actually we do understand that a lot of the learning can be spread through the programmes of work that we've got recurrently. So making sure that our programme of the proactive MDTs, particularly the reactive work that we do, uses the loneliness score. So I will stop there and let's stop sharing my screen. There we go, so that I can give others the opportunity to share their programs.
We'll move straight on to the next one. We'll come to questions at the end. So I think we've got Karen on the call somewhere. Karen Barkway. Hello, Karen. There you are at the bottom there. So Karen's come to talk to us about a quite different scheme altogether. And I'll let Karen introduce herself and talk you through the scheme. You've got a couple of minutes, about 5 minutes, Karen.
Okay, no problem. Hi everyone, Karen Barkway, I'm Head of Primary and Community Care Transformation in Croydon, and I have to send apologies actually from the consultant palliative care lead on this one. Unfortunately, she couldn't join us, but Dr. Holly Young has been absolutely fundamental in developing this and moving it forward, along with a couple of the others in the palliative care team. So could we take us through to the next slide, please? So I'm just going to talk through a very brief overview, and before I start on the content of the slide, I just simply wanted to say that this work has really sits within the context of the Croydon End of Life Care Community Service approach, to bring together the various elements of the services as part of the wider integrated community network team that we have, using all of the resource across voluntary sector, social care and wider. So whilst this scheme is very much based within A&E, the idea is that we can actually support getting people out into those community services as early as possible and really provide that holistic support. So this is a project that was termed PalliTrigger. It's a palliative care trigger tool that the CHS team had been developing, and we identified that actually we needed a little bit longer to test this, so the innovation funding was perfect to be able to have some dedicated resource for a 4-month period, Monday to Friday, to be able to review patients as they attended A&E, to work with the A&E team to understand the needs of those individuals. And we know that approximately 30% of inpatients are in the final year of life, but getting that identification early and really being able to put the support in place straight away is really challenging. And this does also sit within the NICE recommendations for Trigger tool. So as I said, early identification is absolutely clear. And of course, as part of that early identification, it's improving the quality of life for that individual and their carers, their family, and enable people to start making choices as early as possible and really defining where they would like to die. And of course, then there's the system impact of reduced A&E attendances or admissions, and really providing that support to manage pain, to manage the next stage of their journey, really through that end of life period. So we've done an awful lot of work overall across the system to make sure that we've got the clear and consistent plans. And as I say, that is is predicated on identifying people early, and to provide a good death. Also, there's the element of releasing bed capacity across the hospital, really avoiding ambulance conveyances, which obviously from a system perspective is going to make a big difference, particularly through the winter period. So we were trialling this through kind of Q4 into kind of early spring. But one of the things that we have a particular issue with, and this is recognised nationally in terms of the impact, is that our BAME community very often are far less likely than any other group to have an urgent care plan. And therefore, early identification and development of that plan really makes a huge difference in the likelihood of dying in hospital. So that's kind of the context of where we are. If we could go to the next slide, please. So we've had somebody in the team, so working within A&E for 4 months, and over that 4-month period, bearing in mind it's Monday to Friday 9 to 5, that, you know, we didn't have a 7-day service. There were 123 people identified at end of life. 36 of those died, but it enabled that advanced care planning and really to make sure that everybody is cited on the plans for that individual, and not just the plans for that individual, the plans that that individual would like to see happen. So it's very much based on personalised care. The urgent care plan was created for all of those identified through the PALI Trigger tool. And in terms of kind of system impacts, we can actually demonstrate that for those that were assessed in A&E and admitted, but had the urgent care plan through the review of this tool, actually reduced the length of stay by 8 days. And when you consider that these are people that are quite near the end of life and possibly have weeks or days left, those days make a big difference to that quality of life. Obviously, it also helps us with managing the system and challenges. So that experience has been really key, and we've got a couple of case studies that we worked up, but we'll share those through other forums. But the verbal feedback has been really positive around having that conversation, and having that conversation with the right person who has the training and the skills to sensitively broach the subject and talk through. And it's one of the
Karen.
Sorry, yeah, okay. One of the positives with the that we had fed back on one of the case studies was that actually, had this been discussed as part of a much wider medical plan around potential for end-of-life needs, it may have been declined at that stage, but because we had somebody that had the time to talk through, even in a very busy ED department, that actually it meant that they were open to having the conversation and planning, and could therefore be supported in a much more holistic approach. We managed to enable 56% of people to achieve their preferred place of death, and that's generally home. And this is an improvement on the current baseline that we've got at the moment, so is significant and is demonstrates actually small changes can make quite a bit difference. And where the team also looked at the length of stay for people that had the usual care and those that were reviewed through the PALI Trigger tool, and there was a difference in length of stay as well there. So we are able to demonstrate quite a good impact. So we're wanting to continue this. So again, key learning is early review of patients made a difference to individuals, their families. It improved symptom management, pain management because of early administration of medication. We were able to support people to go into the community services so that they weren't reliant on acute care, and really got the care that they need across the plethora of the end-of-life services that are available. It enabled that conversation, if it hadn't already taken place, to support identification of goals, needs, both for the family, the patient and their carers. And that continuity of care meant that we were avoiding people needing to come back to A&E for further support. It became much slicker, much more supportive, and that, as I say, sits within the amazing work that all of the community teams out there, whether they're voluntary sector or NHS or social care, to support these individuals. So we are looking at how we use this learning within our Frailty Front Door team. So that's a piece of work that we're looking at, and we're also seeing if we can identify how we might be able to continue this work going forward. And
That's great. Thank you, Karen. Thank you for sharing that. Ruth, shall we open it up to questions for the 3 different schemes?
I'd love to be able to do that, Angela, but I am very
Running out of time.
And the fact that we do need to talk about the 23-24 scheme. I think the conversation in the chat's been really interesting because it's very much around the theme of how we're going to share this learning. And I think rather than just distributing the contact details of the various people who are involved in these projects, we do need to think going forward how we're going to do that in a more structured way. But I'm keen for you to move on to the next bit. I mean, all three schemes have been absolutely fascinating and show the value that this innovation funding has been able to provide. But I think we do need to move on to the next section and talk about the 23-24 scheme.
Absolutely. Okay. So you will have all found within your papers a document that outlines a revised approach for the 23-25 investment fund, encompassing both strands, the health and equality strands, and also what was previously known as the Innovation Fund, which we've renamed the ICP Priorities Fund to just be more aligned with the work that we're doing over the next phase. The paper sets out essentially a revised allocation for the fund, splitting it into two different pots of money for both the Health and Equalities Fund and the Investment Fund, and also outlines a revised approach for how we would how to disseminate the money over the awards process period. So I'll take it as the paper has been read and call for any questions.
So I can see John wants to come in, John.
It's more of an observation, Angela. We've just heard from three great presentations about stuff that has worked last year. So I think it's really important going forward that we, continue to do the stuff that's already worked, because we could start all over again, couldn't we? And 1,000 flowers and all that sort of stuff. So there's a real opportunity with this fund to capture the stuff using the evaluation of the things that have already worked and roll them out where appropriate across South West London, but then leave an element of funding behind to concentrate on new types of innovation which could potentially come forward for next year. So I just want to say, I think that should be a positive direction of travel as opposed to starting all over again.
I think that's a really important point. Do you want to come back on that, Angela?
Yes, so I suppose within the paper we propose for the Health and Equalities Fund that 75% of the allocation for the following 2 financial years is awarded to the existing schemes, so ones that are determined to continue for the next period, and that 25% of that fund is awarded for new schemes, so that we're not losing the opportunity to come forward with new ideas as well. However, for the ICP Priorities Fund, it is different in its nature from the schemes that we ran in the Innovation Fund. That fund was very much focused on winter, and the new ICP Priorities Fund is focused, as we know, on the ICP strategy priorities. So they're slightly different. I think there are discussions ongoing locally, I know, for a number of the schemes at Place through the Innovation Fund for last year around how they will continue, and they are being assessed within those places, and for the South West London programmes being assessed within their existing programmes. So I think there's a future for them.
Thanks, Angela. And there's a wealth of information here and experience. I'm wondering, maybe it's something we can take away to think about having some sort of depository section on the website where we can put some of the feedback and some of the learning from these schemes so that others can benefit from them as well. Let's have a think about that going forward. Sarah, do you want to come in?
Yes, thank you very much, Ruth. Very quickly, one practical point. Can we please make sure that we do not publicise the fund before, say, middle of September, so we avoid the summer, and to make sure that everyone is, around and able to apply if possible. And the second one is about the 75% of the Health Inequalities funding that is allocated to existing projects. I was wondering if we can make sure that the Place executive committees that are going to decide which ones are getting the continuation of funding and which ones are not, give themselves a deadline to make sure that the present groups know, say, by middle of December, whether they got continuation of funding or not, because obviously they've got staff to make redundant, and there is a month, kind of 3 months notice period normally to consider. Finally, last point, workforce development. I know that 80% of the former Innovation Fund, ICP Priorities Fund now is around workforce development. I'm a bit concerned around understanding of the sector that the sector will have around workforce development. So I just want to make sure that we publicise it and we communicate it in a way that is accessible to them, where they can understand their role into it, and also maybe empower people, encourage people rather to actually do partnership bids with the voluntary sector. And I'm more than happy to be down as a name if people need ideas.
Thanks, Sarah. Andrew, do you want to come back on that?
Yes, so thank you, Sarah. That's really useful. Around the middle of September, I think we were thinking of September, so I'm sure we can take that feedback into account as to where we could move it. It's just a matter of weeks to make sure that everyone's on board. You'll see from the process in the paper, we're looking at about 14 to 16 weeks, but as it runs until the end of March 2025, there's a long period there for people to actually move on and deliver. On your second point around the 75% for existing schemes and allowing place in the system level schemes to make a decision on those and let people know. My colleague John on the meeting here today is responsible for the Health Inequalities Fund moving forward, so I'll let John respond to that one as to whether that's a deadline he would like to suggest is set for health inequalities. And then just finally on the 80% on the ICP workforce development, we've had a brief conversation, haven't we, already today, and I know that Rachel's offered as well for you to become more involved in the ICP workforce strategy group. And I think through that and also through your support to, I suppose, open people's eyes a bit to almost the potentially different ways that you can deliver some of the innovations that people are thinking through is really important. And we talked about almost starting to pair you up, didn't we, with maybe some of the acute sector folk to help them think through things slightly differently. So it's with your support and your colleagues' support, I think we can come up with different ways of doing things. People might have the idea, but actually the execution might be really quite different. So yes, we'll be looking towards you, Sarah, and you, Alyssa, as well, to bring you in to help stimulate our thinking where it might be getting a bit stilted. So yes, thank you. But I'll let John answer on that second part on the health inequalities, the 75% and when people would make a decision.
So before we make decisions, I think it's clear we need an evidence base or some evaluation from the existing projects. So whether it's a place or at system level, we're clear that actually we're going to get some value for money. And if that's the case, there's no reason why places couldn't give their perspective on what did and didn't work. And don't forget, Sarah, I'm kind of thinking about how we would roll some of these out across the system, having built in that learning, and mindful of the different contractual arrangements that VCSEs would have for some of their staff on the books, that we tried to do it soon as we possibly can, but within the sort of the realms of getting the process right. One question back for you, Sarah. In terms of big national charities and their funding arrangements, is there something where the voluntary sector consider how it can bid for some national funds which may or may not be available, which we can draw down into South West London? Does that process exist for the big national charities, or am I just, dare I say, ignorant of how their funding streams work?
Local CVSs tend to engage much better with medium-sized, localised charities rather than the big national charities like Celia UK or the like. So we do have good relationships with the ones that have a branch in place, you know, in the area. But yes, why not? I mean, we definitely can start looking into initiating those relationships with the national charities to bring more funding into the South West London system. But I always think that local organisations need to be prioritised, and they need to be part of the conversation and engage in the delivery, because they know their communities are best. That's really the reality. They're very local, they know the local communities, and they're really very much into the diverse communities they service.
I think that's a really good point, Sarah, but it's also John's comments made me think about external funding sources, and potentially let's have a think about you and I, if there are places like London Funders, City Broad Trust, if there are places where actually the partnership could make some bids for funding, and then think about how we can ensure that locally at place level we're able to take advantage of that. But I think potentially there is a possibility there of thinking about bringing in more external funding. I'm conscious of time, so I'm going to take comments and questions from Anna, Alyssa and Peter McCabe, and then we'll move on. Anna.
Thank you, Chair. A pragmatic approach to continue some projects and the case for ongoing investment in new. However, it does feel like a default position because of the money arriving late and because of how the bid process worked. And with some exceptions, the funding was largely short-term. I do hope, so, however, that because we've now got the joint forward plan, that we will be able to take a more strategic approach across the partnership on how we use the money to enable us to have a longer view and ensure sustainability. Thank you.
I think I know we'd all agree with you, Anna. I'm going to take that as a comment rather than a question, because I'm absolutely sure that everyone would agree with you on that. And it's something that we need to factor in going forward. Alyssa, do you want to come in?
Yeah, I have 3 questions, if I may. The first is around the Health Inequalities Fund. For those projects that are applying for continuation of funding, is there an expectation that they have a plan for scaling up? The other question is really more of a point. I think around the Innovation Fund, even though we have this separate pot for health inequalities, I do think that projects should be looking at addressing health inequalities, even if they're applying for that investment fund. And even though it might mean that we can ultimately fund fewer projects, taking a look at the projects that were funded last year, some but not all had quite small cohorts where it wasn't really possible to detect health inequalities or to learn how different communities might need different adaptations to their interventions. So I think going forward, that should be one of the selection criteria, that the projects have a plan for addressing and looking at health inequalities. And thirdly, just again, in terms of making sure that we're getting the best value for money, I think that we should have a plan for external evaluation of these projects, making sure that there's not that bias that might come from the project teams in evaluating themselves. Thank you.
Thanks, and I think absolutely second and third points really well made, and we need to take them on board. The answer to your specific question, the first question, who can come in on that? Angela, is that yourself?
I think that's a John response on the Health Inequalities Fund around whether continuation would require scaling up.
Yeah, John?
So can I sit on the fence on that one, Chair? Because I think there is something about small projects can be great, and they don't necessarily relate across PAN systems. So I would have an open mind. So if something works brilliantly in one part of the patch but isn't necessarily scalable, that doesn't mean it's a bad thing. But ideally, we'd want to scale up some stuff as much as we possibly can. And I'm also just clear that just because large numbers of people aren't being touched by a program doesn't necessarily mean to say they don't have an intrinsic value. So the digital program with regard to homeless citizens within our communities is a classic example of that. Something's incredibly valuable, even though supposedly it's only a small cohort of people, but it's an incredibly vulnerable cohort of people. So I think it's just balancing all of that, but making sure we try and do as much as we can for as many people as we can, but not making sure we don't leave some folk behind just because it's a small project.
Absolutely. Yep, I hear that, and it's how we ensure that we keep that flexibility, but also the people who need it most, people who are benefiting from it. And it's going to be complicated. We'll work it out as we go along. It's a learning process, which isn't a way of me fluffing it. It's simply recognising the complexity of the issues that we're talking about. Peter, do you want to come in?
Very quickly, Ruth. When John mentioned national charities, I was somewhat confused about what exactly he was meaning. I think you may have had one interpretation of it, but in my mind, having worked in the voluntary sector for 42 years and raised quite substantial sums from charitable trusts, that have a national brief, I wondered whether that's what he was driving at, or whether he was talking about the big national charities such as British Heart Foundation or MenCap, or any number of them that have substantial incomes. And we need to be clear about what we are talking about, because if we're going to be trying to generate resources for projects, we need to understand what their constraints, what their rules, who they can give to, and so on. Now, I don't think we can have that conversation in here, but I didn't know what exactly John was driving at.
Fair point. John, do you want to come back in?
Yeah, thank you, Peter. Happy to clarify. Yeah, I'm thinking about us in South West London looking out at some of these big national institutions, charitable funds, and perhaps thinking, can we find a way to bring some of that resources into South West London or into our places? So obviously we've got small seed funding here, which is coming through our funding, but actually there might be an opportunity if we looked out that we could attract funding in from other places, which is what I was referring to, if that makes any sense, Peter.
But many of them will only give to registered charities as opposed to partnerships such as ours. So we need to be, very clear about what their criteria are if we're going there.
Yeah, I misunderstood, John. I thought you were talking about national charities, but you were talking about national trust, and foundations. So yeah.
I was talking about both, actually. I think we can look at both, to be honest with you.
Both, yes, absolutely.
And you're right, Peter, that if we're making a funding bid, it needs to come from a charity, but we could have a lead charity that's leading for the partnership. So let's explore some of this. Money is tight across the board, so any external funding we can bring in, I think, would be welcome without losing that local focus. So I think we've got a real opportunity here. Anja, thank you for all the work that you've done on both these papers, really important. And I thought the conversation in the chat about how we're going to spread the learning was really important. So let's hold on to that. We're being asked to note the progress of the Innovation Fund, the 2023 schemes, which is what we've done, but we've also been asked to approve the approach for the Health Inequalities Fund, the approach for the Strategic Priorities Fund, and to review and support the process for 2023-24. Can we agree that? Thank you. And I'm handing back to you, Mike.
Thank you.
Thank you, Ruth. And that was a great discussion. Absolutely loved the presentations. They were really bring to life what we as an ICP are trying to do. We're going to stick with the voluntary community and social enterprise sector, and we're going to hear again from Zara, who is, I think, 3 months into her formal role as Chief Executive of the New Alliance, which is fantastic news. Congratulations, Zara. I'm going to ask Charlotte to introduce this item.
Thanks, Mike. Yes, I'm delighted to introduce Zara. And I think we can all agree that engaging the voluntary sector is really crucial for our success as an ICS, bringing together all that expertise and unique perspective, but also resources, because we know that across South West London, many hundreds of vulnerable people and families completely rely on voluntary sector in a big way, really, to deliver care every day, working alongside our statutory organisations. And I know Zara's got some great things to say about how we help our system recognise that significant role played by the voluntary sector in supporting our communities, but also seek your advice really on how we foster that collaboration and communication. So over to you, Zara.
Thank you. Let me share the presentation. Can everyone see it?
Yeah, that's great.
Yeah, okay, great. So it's going to be a very quick presentation. I understand I've got 5 minutes, so I'm going to try to be as quick as possible. The presentation is about the voluntary sector in South West London and how can we integrate it into the ICS and make it an equal and impactful partner. As you all know, the voluntary sector has got lots to offer. We are really rich in flexibility, creativity. We've got knowledge of our community, and we always work on an asset-based community development approach. So it's all about co-production and co-design. We've got loads of data to offer to the ICS, mainly qualitative, but also quantitative. We want to be commissioned, of course, we want to be delivering services with the ICS, but we also want to be partners in planning and designing. And we're very big at reducing health inequalities. It's all about prevention and reaching our diverse communities. So South West London, we've got about 5,500 groups in South West London, and about half of them will be registered charities, but the rest will be CIOs, social enterprises, unconstituted groups, And this is the amount of funding the sector raised in 2021-2022, and that doesn't include social value, from the support of volunteers at all. So it's quite a significant amount of money. When we think about voluntary sector, some people think about the national massive charity, and some people think about the residents association around the block. But actually, there are a wide range of groups in between. And I think it's really important that we understand what they look like and how can they get engaged with the ICS. So I've got 3 examples. The first one is Helmet Care and Community Services, Kingston based. So they provide the usual medication support, daily living at home service, but they also are more of an holistic organization. They have a drop-in center offering activities so that they can reduce loneliness and isolation. They give training, education and peer support groups for carers. 3/4 of their staff are from a BME community background, and they've got more of a social enterprise approach. So their challenge would be probably to, they won't have the capacity to probably apply to a big tender, and they will need a little bit of flexibility with their contracting arrangements to make sure that they, serve at best the residents they work with. Next, Alzheimer's Society. Who doesn't know the Alzheimer's Society? They're quite big. They've got different branches. This one is in Merton. They did a memory cafe, so people could pop into the cafe and talk with an expert about their worries around memory, whether it was for themselves, their friends or their family. And they were actually funded by the NHS South West London and Merton Council. So a group like that will have 12 employees, maybe 20, 30 volunteers, and they will have the structure, the ability to put in partnership bids and put in, tender bids. And then we've got a different organisation. This is probably the tiniest amongst the 3. 1 member of staff. It's in Croydon. It works in New Addington, which is a very deprived ward in Croydon. And they see about 70 to 100 residents per week. So these are all people that are socially isolated. They've got poor mobility. They live in by themselves. They've got a minibus service, bring them to activities, and they do all kinds of things. I mean, apart from building friendships, it's a space to buy clothes and other items because they're not mobile enough to go to the shops. And it's a place where they can get a haircut even. So organizations like this, their challenge will mainly be the fact that they're very local. They're too small to compete in competitive tenders. And a group like that would really suffer from loss of funding. So, for example, they lost completely their funding from the council this year, and now they're trying to find new funding, alternative funding, and it's going to be a challenge. But a group like that can have a massive impact, when we come to prevention, especially. So this is what the Alliance has done so far. You can see that, as we know, I got into place in April. Since then, we've been mainly looking at governance. Terms of reference, we have been looking at representation across the board and a remuneration policy for reps. We have just had an MOU workshop, so looking at kind of drafting a memorandum of understanding that I will then bring here between the ICS and the VCSE, how we want to work together. We've got an event coming up in October that is likely to focus on workforce development. And after that, we're likely to focus as an alliance on work streams. So we will pick 2 or 3 work streams from the ICP priorities and do pieces of work on them, engaging all the voluntary sector across South West London. And this is how we link up with the local voluntary sector infrastructure organisations. We've got a leadership group with 6 people at the moment on the board. Each CEO from each CVS is on the board, but now we're extending it to include maybe other 6 with particular experience around the ICP priorities. And yes, so these are the values that we found most important, and I hope they resonate with you. And I'm always only going to touch on 2 because I know I'm running out of time. But the 2 I would like to touch on are equity. and pragmatism. So we want the voluntary sector to have an equal voice and influence through the Alliance. We want the voluntary sector to be a must-have partner. So when people think about working in partnership, you know, they think we must have the voluntary sector because we're key to prevention, and we really think we can connect you to the diverse communities you want to connect with. But we also need you and us to be pragmatic. So if we want the relationship to work, we also need to facilitate contract and funding arrangements that are sustainable for the organizations. And we all know, you know, the challenges of invoicing, PO numbers, contracting. They seem technical, but they really make a difference even in the willingness of voluntary sector groups to engage with the ICS. So my next slide is about asking you, how can the ICP work genuinely in partnership together? So what are the steps that we need to take to ensure that all the partners understand the complexity of the voluntary and community sector, and we increase you know, the opportunities for successful outcomes? How can we build that trust? And that's me. And I'll leave it as an open question. I'm going to stop sharing in a second, sorry for my...
Sarah, thank you for that. And I think that gives us a really good flavour of the importance of having an alliance, which allows us to speak to through one organisation to 5,500 organisations. Now, I thought I knew quite a lot about the voluntary sector in South West London. I know we have a hugely rich voluntary and community sector. I didn't realise it was quite as large as that. I spent 10 years in Croydon, and I thought we had about 500 community organisations, and there's nearly 2,000. It is absolutely rich, and I think it's really important you shared with us that they are everything from those very, very small organisations, maybe not even with a paid member of staff, to the organisations like Age UK. We've got Brenda here today, who are key delivery partners for the ICB in mainstream programmes of work. I think throughout the course of today's meeting, we've identified a whole range of ways in which we're going to take practical steps to ensure that the voluntary and community sector is fully engaged in all of our work, that you're embedded in all of the work streams, and that that aspiration that you put on there, that by default we work with the voluntary sector rather than by exception, is going to be really, really important as we move forward. Happy to take a couple of comments, but I'm aware that we're sort of running close to the end of the meeting. And I think that with Zara here, we've actually made a lot of contributions throughout the session to the ongoing involvement of the voluntary sector. But if there are any particular points anybody wants to make, I'm really happy to take them at this point. Can't see any hands going up. Zara, that's not because people aren't interested in this programme, but I think as this has come after we've also already got so many commitments to further engagement with the voluntary sector, this is just a piece of information which is absolutely reinforcing. And as I say, it is great to learn something new, and 5,500 voluntary organisations in our bit of London is amazing to know. That is a real asset for us to work with, and we need to make sure that we exploit it. Before I close this, is there any sort of final comments you'd like to make, Zara?
No, absolutely not. Well, I'll leave my email address in the chat, so if anyone wants to make contact, please do. I think we need to start those conversations, and we need to have difficult conversations quite early. And what I also wanted to add from my slide actually is that what I think is really important is having a can-do type of attitude during those conversations, because we know we've got different cultures, we know we've got different protocols that might make things difficult and slow, but there is always a way. And yes, so please contact me.
Sarah,
I'll drop an email in the chat.
Lovely, thank you. Zara, you're absolutely right. That can-do culture is absolutely vital. There's always 100 reasons for not doing something, but there's normally 1,000 reasons for doing something. And it's the 1,000 reasons we ought to follow rather than the 100 reasons not to. I'm going to pass back to Ruth now for the sort of any other business, which I know we've got a sort of significant item that we're keen to put on the table at this meeting. So Ruth, back to you.
Thanks, Mike. And I have a technical problem. I'm interested to see that Carolyn has the same problem. So clearly it's a problem with the software here at Sutton Council, that when the presentations are taken down, I can only see a blank screen. So what I'm going to suggest is the only way to solve this, I've discovered, it happened at the board as well, is for me to come out, to leave and then come back again. While I'm doing that really quickly, Zara, would you like to share with the members of the partnership board your idea about having a marketplace at the end of these meetings? I think it's a really interesting idea. I've shared it with a few people already. Would you mind just explaining what you have in mind while I quickly come out and come back again? Thank you.
Yeah, no worries. So what Ruth and I were thinking was to maybe have at the end of the meeting, we could maybe the one in, I think we've got one in October coming up. When is the next one? I can't remember, but the next one in the autumn that is coming up, we could finish the meeting slightly earlier, say half an hour if possible, and then invite voluntary sector organizations around one specific priority of your choice to introduce themselves, to talk to you, to engage with you, so that you can kind of meet the different, you can meet a range of professionals, a range of organizations across the 6 boroughs, get to meet them in person, and for them to show you what their work is about and what they can offer to the ICS. So that was the idea, really. And Ruth and I were actually considering whether to do it within the ICP or the ICB meetings, because I think the ICP, the ICP meetings tend to be in the morning. No, sorry.
ICBs
Help
are
me
in the
out,
morning, and
Michael.
ICPs are in the afternoon. So
So whatever.
We'll have a conversation about this, Sarah, because obviously, if you're asking voluntary groups, I'm back, yes, hey. If we're asking voluntary groups to come along, probably an evening meeting is not ideal, but let's have a think about this. And I think this is about raising awareness. I'd be quite keen to see it linked to a particular agenda item, rather than asking all, the voluntary sector, as you've very clearly explained, is made up of many, many thousands of organisations. But I think it was telling what you said, Mike, and it's my experience too. We don't know just how many organisations are working. So possibly linking it to a particular agenda item, I think would give that added meaning. And let's have a think about whether it'd be better to do it with the board, the partnership. But the idea of having a way of physically meeting up with people. It was the feedback from the conference as well. People said it was so powerful being able to meet in person and have some of these discussions. But it's very much about raising awareness and thinking about how we can work together. So you and I can have a think about that, and we'll discuss it with Mike and Sarah and others and see how to make that happen. The other item that we wanted to talk about under AOB is that I've had some really helpful feedback from several members of the partnership about how we can better co-design the actual agenda, the discussions that we're having. Certainly one of the bits of learning from today is that all the presentations were just brilliant, and I wish we'd had more time. So we probably need to think about lightening the agenda so there is more time to discuss. Otherwise, it does feel very, very rushed the whole time, which is a shame. The presentations are absolutely fascinating. So let's think as we design the agendas going forward to make sure that we have enough time for discussion. But this is also about, this sounds a bit nerdy, but it's really important, forward planning. So we're keen to have input from members of the partnership about what you would like to see on the agenda going forward. So we're going to start to build a forward plan, and we'd like to encourage you, I don't think we can do it now in this meeting, but to encourage all of you to come forward with proposals and suggestions for future meetings. There will always be times, obviously, when stuff happens, and we've got either because of particular events or because of dictates from other parts of the system, there will be a need to put certain things on the agenda with quite short notice. But I do think we've got some big issues here, things that we're particularly concerned about, things that we want to be able to explore in more detail. So this is a call out for anyone that has any ideas, any suggestions about what needs to go on the forward plan, to think about what could go on, and we will make sure that in the agendas going forward, we're leaving 5-10 minutes to have this sort of discussion. A very strong request has come forward, which we're happy to take on board, and the request is that at the next October meeting of the Partnership Board, that we have a discussion around the future of paediatric cancer services across South West London. Obviously, many of you will be aware of suggestions that are being made, proposals, and we would expect by October, when we have our meeting, to be in the middle of the consultation period. Obviously, you know, some of you, because of the organisations that you're representing, will have different views, and that's absolutely fine. But we thought it would be good to have a general conversation, but also to think about who are the sort of people and organisations that we'd like to come along, so that we're ensuring that people's voices are heard. I think it's unlikely we'll want to respond to the consultation as a partnership. It may well be that we decide to do that. I think it's more likely that the places will want to decide. But it seems to us that this is such an important topic that's going to impact on services across South West London and the wider South East, that this is a conversation that it would be useful to have. I don't know if the people who's proposed that want to come in at this point and just add some extra depth or colour to this, but that is the proposal going forward, and we're suggesting that should come to the October meeting. And I'm happy for any of you to come in, but also to say that there's been an interesting request to think about our buildings, our assets, partly from an environmental point of view. What's the role of the partnership in helping us all to achieve our zero carbon footprint? And I've seen some interesting data that shows that actually, particularly in South West London, it's as much about our buildings as it is about transport and the vehicles that we're using and our public transport or not to get about. So we're thinking that for a future meeting, having a conversation about our buildings, particularly our hospital buildings, and how we can share some of the learning, some of the experience. I know that in local government, we've got a lot to contribute here, because we're doing a lot of work around how we could show, lead by example, and show how our council buildings, and I would argue our primary and secondary care buildings, are also ensuring that we reduce our carbon footprint and are fit for the future. So most definitely there'll be discussion there. We know that some of our hospitals are really struggling. There's been a lack of investment over a very long time, and we need to think about how we're going to go forward and ensure that all of our buildings, but particularly our hospital buildings, are fit for the future. So those are some suggestions that have come forward, and we're very happy to take them on board. I'm happy to bring in anyone that would like to contribute to any of this, any suggestions about what I've said, or any other ideas that people have. Annette, do you want to come in first?
Yeah, hi, I'm Annette McPartland. I'm representing the DAFIP across South West London here today. I think what it would be an opportunity for, adult social care is going into assurance and inspection, and it's how and with the ICS, and how we interlink and interplay our assurance and our readiness. There's a huge amount of work that's going on, and we're working across all South West London. And I think it would be good have a discussion in the paper here on how the partnership could help for us to be ready for inspection.
I think that's an excellent idea, Annette, and without outing the person involved who isn't part of this partnership meeting, we had an event in Sutton to celebrate the 10 years anniversary of Health Watch, and one of the trustees told me that her day job is actually to write the guidance. So I know who she is. I don't want to put her on the spot here, but I might go back to her and ask her if she's willing to come along and just give us some insight into where she thinks it's all going. So, but I do think that's really important. I know there's a lot of learning to be had from children's services, because they've been in a similar sort of inspection regime for some time, and I know that across South West London, I'm sure that people working in adult social services, I can see Anna nodding, will be happy to share that experience. But this is something new, and I think it's important we get it right. So absolutely, let's add that. Peter, do you want to come in?
Thank you, Ruth. I was one of those who raised the issue of children's paediatric care and the proposals for that. And I think it's perfectly reasonable and legitimate for us to discuss such issues in this partnership. And I was a bit surprised that there was some kind of challenge to that, because I would have thought that as members, partners in an enterprise, that you know, a number of representatives asking for that with a democratic mandate to raise issues on behalf of their communities would be given a hearing. And so I support that and would like to see that. I also raised the issue about estates and hospital estates in particular. I was less concerned, although it's an important issue, about environmental matters, as hospitals that are practically falling down as a result of a lack of investment over an extended period of time, which affects your constituents in Sutton and mine in Merton. And it's something that is being raised regularly with me. And I think that that's something that we ought to be discussing here. And again, I'm concerned that people may try to prevent such a discussion taking place. And if that happens, it will call into question whether this is a partnership or whether it's something that we're here to listen rather than to contribute.
I'm a little bit puzzled by those comments, Peter. We've already had this discussion. I explained to you the issue isn't about challenge or trying to stop us having conversations. It's simply to understand that there are similar conversations going on in other places. There's a joint overview and scrutiny committee across the 6 boroughs, which is looking at some of these issues. That doesn't mean we don't discuss it here. We just want to make sure that we're not duplicating, that what we're doing is adding value. So you use the word challenge, that's fine, but it isn't that anyone's trying to stop a conversation happening. It's simply being very clear about the remit of the various parts of the jigsaw puzzle and how we can come together in a more meaningful way to ensure that every part of the system is actually able to have the opportunity to express their views, which is why I am suggesting that we have exactly that conversation at the next meeting. John, do you want to come in?
Yeah, not on this subject. I'm just wondering, is it possible to hear about challenges and developments in, let's say, areas such as housing and education from a partnership perspective, because they're such an important part of the wider determinants of health, which we've talked about with regard to the strategy and the joint forward plan that we've gone over. So, you know, I think about things from a health perspective, but I am aware that there's a wider world out there, and perhaps that's a partnership opportunity to share in some of that.
I think that's a really interesting idea, John. We'll need to go away and think about that carefully, because it feels that we're talking about everything there. You know, we all recognise from Marmot and everyone else that the wider determinants of health are actually, I think it's 80% of the impact that it has on people's health. So I recognise that. I'm just thinking about how we can do that in a way that's quite focused. But let's take that on board. So we've got a list of suggestions here, which is absolutely fine. We're going to be, as I've explained, at the October meeting, looking at the proposals, and we'll have the consultation, presumably by then, looking at the proposals for the future of paediatric cancer services, and then we'll take on board these other suggestions going forward. But that seems to me to be a good way forward, and I'm glad that we've had this opportunity to talk about it. Mike, I'm meant to be handing back to you, but shall I just close the meeting, because it seems I'm just going to keep going. And
I suggest you should close the meeting, as we have no.
So I'm pleased to see we are on time, which is a good thing. I do think that for the next meeting we need to try and think about how we can have fewer items, because the contributions, the presentations that we've had from various groups has been absolutely fascinating, and I do think we need the opportunity to have a bit more time for discussion. So let's think about how we can frame the agenda going forward. I am going to bring the meeting to a close now. The next meeting is on the 4th of October in Wimbledon, Hotel Antoinette. So I'm going to close the meeting there, and then just let everyone know that we didn't receive any written questions in advance of the meeting, so there won't be any questions to take. Can I thank you all for the time and the dedication that you've given to the work that we're doing here. Partnership working is always complicated, a bit messy, takes much longer than some of us would like, but actually it means that we get to a better result. And I think this is an absolute focus of the way that we're taking this work forward. Can I thank again everyone who's made a presentation here, and also thank people who have been working so hard behind the scenes to enable us to have the reports that allow us to do the work that we need to do. Thank you everyone for how engaged you are. Enjoy the rest of the evening, and I'll see you all soon. Thanks very much. Bye.
Thank you.